Today, we're going to be discussing our practice improvement proposal, which is focused at UNC Health Chatham.
So today we're going to be giving you an overview of the setting, the service gap that we identified. We're going to explain our proposal in depth, go over some influential factors that might affect our proposal, our bottom line, and the conclusions that we've made.
So UNC Chatham Health Hospital began in 1937 as a two-story brick home to serve individuals in the rural western region of the county. And so it is now part of the UNC Health System and has been since the year of 2008. It has been designated as a critical access hospital, which means it is designed to help reduce both the financial vulnerability of rural hospitals and improve the overall healthcare access within the rural communities. So the mission of UNC Chatham Health is to support the health and well-being of those we serve through quality, equitable healthcare, and to build partnership within our diverse community. Their vision is to be the provider of choice for our community while continuously improving to lead rural healthcare. So it has now grown to a 25-bed hospital that emphasizes providing quality care to the residents of Chatham and its surrounding counties, which include Durham, Alamance, and Orange. It serves around 14,000 patients a year. And so it provides the community with access to emergency services, surgical services, imaging and radiology, maternal care, cardiac services, diabetes education, rehabilitation services, post-acute care services, and it also provides health services through community-based outpatient clinics. So it's important to note to remain a critical access hospital, they must follow specific guidelines, such as being located more than 35 miles from the nearest hospital, having no more than 25 patient or inpatient beds, and annually having an average length of stay of 96 hours or less per acute care patient. So a general overview of the acute care setting. So specifically, the interdisciplinary team consists of the MD, case managers, PTs, OTs, nurses, and pharmacists. So they all work together and have morning meetings to discuss the important patient information, such as certain patient needs, identifying any concerns, and discharge needs of the patients. So they all collaborate together and provide insight in their area of expertise. And then the role of the OT in the acute care setting includes evaluating the patient's discharge needs. They help determine what is best for the patient when leaving the facility, which may include home health or outpatient services. And then they also address any need for adaptive equipment and provide that proper education on how to use the equipment. And they assess patients' cognition and physical needs. So the most common cases in the acute care setting, this may include fractures or worsening conditions due to infections. Also, this setting has an increased rate of repeat patients due to poor hygiene and care within the home. So as mentioned above, UNC Chatham, it qualifies as a critical access hospital, which is eligible for hospital facilities located in rural areas through the centers of Medicare and Medicaid. So a critical access hospital is designed to limit financial vulnerability. So benefits such as cost reimbursements for Medicare inpatient and outpatient services are given, which allow for hospitals to be reimbursed 101% for the cost of services. There's also something called the PPS, which is a system where payments are set ahead of time and before the services are delivered. So no matter the cost they incur, the provider is paid a fixed rate per service. It's also important to note that UNC Chatham Hospital provides their patients with an online resource so they can go on there and select their provider, the service that they may be getting, and then their insurance, and this will tell the cost up front. So some of the stakeholders of UNC Health Chatham include the CEO, board of directors, patients, healthcare professionals, providers, payers, and policymakers. So UNC Chatham, it serves a total population of 79,864 individuals. So 72.3% of these individuals are Caucasian, 12.1% are Hispanic, 11.7% are African American, and then the rest, so 3.9%, are either Asian, American Indian, or Pacific Islander. So out of the total population served, 55% are 19 to 64 years of age, 25.9% are 65 and over, and 18.8% are 18 and under. So some national averages, the average adjusted cost per inpatient stay is $14,101, and then the average length of stay for hospitalization is 5.5 days. A few of the most frequent diagnoses for hospitalizations include sepsis, heart failure, osteoarthritis, pneumonia, and diabetes mellitus.
So the service gap that we have identified for our proposal deals with diabetes management. The UNC Health Chatham's acute care occupational therapist, Hannah Sykes. She's the OT that we have worked with throughout this entire project. And she is not currently involved in addressing the needs of patients with diabetes. Although Hannah should be a part of the treatment team and aid in the treatment efforts of patients with diabetes at UNC Health Chatham, because this falls under her scope of practice. Hannah has observed that the facility has a pattern of acute care beds being occupied by recurrent patients. And we've included some of the possible causes for this service gap. These could be that the healthcare system has a separate outpatient diabetes clinic at the facility, so at this hospital. Another reason could be that there's a lack of OT referrals for treatment of patients with diabetes. And the importance of addressing this service gap would be because diabetes has lifelong implications and secondary health issues that can alter occupational performance and quality of life if preventative care is not addressed and implemented within the daily routines of patients. And we included some more statistics here. So this is diabetes in Chatham County. So 7.7 per 1,000 adults aged 20 plus will be newly diagnosed with diabetes. 8.7% of adults in Chatham County live with diabetes. 19.7 per 100,000 of deaths are identified as diabetes being the underlying cause. And then here are some common effects of diabetes. So you can see that it can cause visual deficits, kidney failure, amputations, depression and anxiety, heart failure and stroke, obesity, and neuropathy. So for our proposal, it consists of two different parts. The first part is to increase referrals for OT. And so we thought that we would accomplish this by having an in-service event. And this would be a really informal in-service event. It would be hosted by Hannah and her OT colleague, and it would provide detailed information for the nursing staff at this facility regarding OT's role in helping patients' performance improve for patients who have diabetes. Included in the in-service event presentation would be signs to look for and questions to ask diabetic patients regarding their ability to manage their diabetes, information that helps the nursing staff better understand how OTs can help patients who are experiencing difficulties with managing their diabetes. So basically, it would just be like an informal presentation just to help nursing staff have a better idea of how OT can help improve the performance of patients who have diabetes. So the impact of this in-service event would be providing the nursing staff with this information, and it would help them be more aware of the situations in which patients' performance could improve from OT services specifically. Explaining OT's role within this area of care will help improve nursing staff's ability to identify when a patient could benefit from OT services, Nursing staff can then talk with these patients' doctors concerning their need for OT referrals. So hopefully this would increase the referral rate. So basically the overall goal would be to increase the amount of referrals for OT for patients who are struggling in certain performance areas that are resulting from poor diabetes management self-care. And for the second part of our proposal, it would be implementing a routine performance screen. So this would be a routine performance screen that would take place in acute care. So like by Hannah Sykes or any other OTs working in acute care. So this screen would evaluate lifestyle routines and habits that impact an individual's ability to manage their diabetes. This would allow the team to better prepare a discharge plan that best this would allow the team to better prepare a discharge plan that best suits the patient's needs and reduce the rate in which these patients have return visits. Some categories that could be on the performance screen would be things like medication management, nutrition and meal preparation and schedule, monitoring glucose levels, and proper management of skin integrity and sores. So why is this routine performance screen needed? The main reason is because these types of needs may go unnoticed by other healthcare professionals because the right questions are not being asked to get down to the habits that are resulting in poor disease management.
So on this screen, we kind of went ahead and did a mock of our routine performance screen. And we did the categories that Holly mentioned earlier. And so basically what we would do is we would use this to kind of dig deeper into the whys. I feel like sometimes some healthcare professionals is so routine with your patients that you're not asking the questions that need to be asked. So this is why we're proposing that the OT gets the referral and has the assessment so that they can get down to the behaviors that are not allowing for optimal diabetes self-management. So I'm going to go ahead and read off some of our questions that we have on there. Some would be, are you having any difficulty administering your medication? If they're using insulin, what sites are they injecting in? Do they rotate their sites? When do they take their medications? Is it before meals, after meals? How many times a day? How many meals a day do they have? And at what typical times? Do they have a routine or a schedule that allows them to have an appropriate amount of meals a day so that they're, doing that? Because when you eat your meals and when you monitor your glucose, it's important to make sure that you're staying within and on top of your management. What kind of foods are they eating? What kind of foods do they have access to? Do they have family support within the home or in the community that also are aware of the types of things that go into managing their diabetes? And when they do check their glucose levels, when are they doing it, and are they keeping a record of it so that they can see what times of day they may get low or high, or just what types of events may cause those lows and highs? So some examples of some patient needs that we might come across is they might be given equipment, but then they don't know how to use it, or they're not given examples of how to use it or demonstrations. So therefore, they're just not using them at all. Their routines may not allow for meals. I know some people's work routines, they may eat before and then they have dinner and they don't really have time for lunch. Maybe they don't like the pain of needles, or it hurts whenever they inject to a certain site, or they don't really just understand the importance of checking their glucose before and after meals. So for the timeline that we're suggesting is 2 months roughly to plan everything, to coordinate the in-service event with the nursing staff. During this time, you can finalize the performance routine screen. Then we want to implement this proposal for a whole year. So that's when we'll do the actual in-service event and then get those referrals, and then OT will work with those patients for a year. The study and evaluation, we kind of want that to be an ongoing process. We do have something that we will have in the patient chart that we'll talk about here shortly. But it's just going to be a tool that will measure how well the proposal is going. So some situational factors affecting the proposal Number one would be collaboration with the nursing staff. Diabetes self-management is typically an educational thing, and that's usually ran by nursing. We definitely want to come in as collaborators, and we want to make sure that they know that we're working on something else that is attributing to self-management. We really want to focus on the performance of daily activities that go into managing diabetes. Second are referrals. Is the in-service working? Are the attitudes of the nurses positive, and are they going to give referrals, and did they take the information that we gave them and go to doctors to meet those needs? Are the referrals that we are getting, are they appropriate? We don't need referrals for every single patient with diabetes, but we do need referrals for people who are having, readmissions for the same things, or if they're getting things that are part of their ADLs and their IADLs, that's when the nurse should flag that an OT evaluation may be appropriate. For the pre-existing diabetes clinic, we see that maybe this could be a problem because maybe some of the stakeholders might think, well, why does OT need to be involved in this when we already have a diabetes clinic? If that becomes a thing, we may need to do some extra research to provide evidence on OT scope and present it to them, and why we would be good to work with them and the things that we can do, such as lower readmission rates via the Rogers article.
So now we're going to look at how we are going to evaluate our proposal. So for the in-service event, we were thinking to do a pre and post survey on how the effectiveness of the in-service event was. So you could do this two different ways, but essentially you would want to do a survey just before and after the event. Now, if you wanted more of a longitudinal results, then you could do even like 6 months or even 12 months after the implementation of the in-service event. The format would be a Likert scale that focuses on the nurse's knowledge and attitudes about OT addressing diabetes self-care performance. And so essentially an example of this would be, as you see on the screen, how likely would you ask for a referral for OT for a patient with poor diabetes management? And it goes from 1 strongly agree and 5 strongly disagree. And these the information from these pre and post surveys we would be able to compare to evaluate the effectiveness of the in-service event. And if we wanted to continue the in-service event for new employees, for new nurses, then we would know how effective this event would be. So the next is the Diabetes Self-Management Questionnaire Revised. This was originally published in an article in 2022, and it's essentially a 27-item Likert scale as well, ranging from applies to me very much to does not apply to me at all. To the side of the screen, you can see a few examples of the questions asked on this questionnaire. So for example, number 23, I adjust the timing of my insulin injections and food intake. And essentially this is going to have the OT implement this during that first eval. And it's going to be a part of the evaluation to assess the patient's self-report behaviors related to diabetes management. And you can also see some subcategories such as medication, eating behaviors, and physical activity, and so on.
And so our resources for our logic model are going to consist of the acute care OT and the nursing staff. Our activities, as stated prior, are going to be the in-service event with the nursing staff, our routine performance screen, that's going to be measured with the DSMQ revised within that patient chart, and then we'll have that pre and post survey with the nursing staff. Outputs, we're really hoping that the in-service will help us to get more referrals, and then Hannah, the OT, will see those referred patients. Outcomes. So we really want to use the DSMQR as a measurement to see how well adjusted patients are getting to the OT interventions, their attitudes about their self-management, if those scores improve. We also want to improve communication amongst healthcare professionals along the continuum of care. So we really want to make sure that us going through this assessment and doing the screen with these patients, that's not going to get lost once they leave us. We want to make sure that we are hitting on those behaviors and we're giving them attainable things so that they can implement that into their lifestyle and take it with them. And then the outpatient OT or whoever they may see afterwards can see that in their chart and kind of go from there and keep working with that. And so then our overall impact is that we really want to make sure that we are helping with the performance of daily activities within diabetes management. So we want to address that, and addressing those things will help to prevent secondary health issues, thus decreasing the possibility of readmission.
So the bottom line, in 2021, it was reported that 1 in 6 residents of Chatham County were told by a healthcare professional that they had diabetes. So that just first shows you that this is relevant to the county and to UNC Health Chatham. Research has also backed up that only half of individuals receiving diabetes education has actually carried out self-management activities successfully. So that just also shows you that, yes, we might be teaching and educating these patients while they're in the facility, or even while after they've been admitted, but it's not sticking. And so that's why we have proposed what we've proposed. And so occupational therapy professionals look at the patient's individuals and alter their plan of care accordingly to the maximum to maximize their occupational participation. So instead of asking, are you doing this? We ask, why is this not working, and how can we make it work for you? Because every patient's going to be different. It's small, attainable steps towards the change that changes the trajectory of these diagnoses for these patients. And ultimately, it's going to reduce hospital waste that's associated with rehospitalization for these patients as well.
So just to go over some things that we've learned along our way during this project. So payment systems. I was not very knowledgeable about payment systems and how much that affects OT and from facility to facility, how they're different. So that was really eye-opening to learn about payment systems in general and just about critical access hospitals. They are incentivized and reimbursed by CMS, so the Centers for Medicare and Medicaid. And they get their reimbursement based on the 101% rule. And they have to go by all the policies, and they have extra regulations that they have to go through to qualify for those. So basically, the CAH, what they're here for is they are here to make healthcare more accessible to rural areas. Next are regulatory factors. So it's really interesting that each place has a system. And what we have to do is that we have to learn how to implement and how to advocate within these systems. And then we also have to be wary of how the changes to these systems are going to impact it. And these are our references. Thank you all so much for listening to us today, and we're going to open the floor for questions.